Hello, I'm Richard Westerby for IV Fertility, and today we've got the amazing Dr. Meredith Brower from Reproductive Partners Medical Group to talk to us about what is a frozen embryo transfer. Dr. Brower, hi.
Hi, thank you. All right, so today we're going to talk a little bit about what is an embryo transfer, how to prepare, what are the different ways to prepare, and just general expectations of what this process looks like.
Yes.
Okay, so in IVF, the final step is the embryo transfer, where once the embryo is made, we need to put it back inside the uterus. Okay. Conceptually, there's really two big parts to that. We need to get the lining of the uterus ready. The lining of the uterus needs to be exposed to estrogen. And we'll talk about the different ways to do that, but it needs estrogen exposure to get thick. And then it needs progesterone exposure to change the nature of the lining so that it's ready for that embryo to implant. So that's what we're doing. There's a couple ways to do it. There's really two major ways to do it. One would be what we call a programmed or medicated embryo transfer cycle. And these types of cycles, we give the female estrogen to thicken the lining of the uterus. And that estrogen can be given by mouth, vaginally, patches, as injections. There's many different ways. And one's actually never been shown to be better than the other. Different clinics will do it different ways, and different bodies will receive it different ways. So sometimes we try different things.
So a question on that,
Yeah.
that if I'm taking injections
Mhm.
and you don't see that it's working, how would you see it's not working?
Excellent
And
question.
can I switch mid go from one to the other?
Absolutely. So when we are assessing if that estrogen is working the way we want, we're doing ultrasound and we are looking at the lining of the uterus and measuring the thickness. Okay. We're also looking at the nature of it. How thick is it getting? And what does it look like? It has this sort of particular, what we call trilaminar or three-line appearance to it in the most perfect world as a response to that estrogen exposure. So your question is, say I'm taking shots, intramuscular estrogen. You look at my lining after about a week, it's thin, it doesn't look great. Usually what happens is you add another form, okay? Or you might change it altogether. So yes, you could then add vaginal or oral or patches. So yes, you can adjust, you can add, you can change in the middle of a treatment cycle. Absolutely.
And the shots you take, is it like a huge needle? Is it a little? I'm like,
How afraid should you be?
yeah, I'm not good with needles at the best of times. So
For the estrogen, luckily, like I said, people very needle phobic we can choose patches, vaginal, or oral. The estrogen it's what we call an intramuscular shot, so
into your bum.
it goes into your bum. The needle, interestingly, it's not as painful as you might expect. We're going to talk about progesterone in a second, and that's a little bit different. But
Okay.
the intramuscular estrogen, it's a long enough needle to get into the muscle. It does go in the bum, but it's not famously painful.
Okay. Can you do it yourself? Because I mean,
People,
like you like reaching around and
there are people who do it themselves. We have single individuals who don't have partners who are often they do their intramuscular shots by themselves. They kind of just reach around and they can do it.
I would never be able to
They
do that.
don't typically choose, those individuals are often avoiding those injections, but we have many patients who do.
I
Yeah.
think I'll be popping the
You'd rather wear a patch.
Yes, exactly.
We could offer that to you.
Okay, perfect. So we're
So
thickening the
we're
uterus.
we're thickening the lining of the uterus with some version of estrogen. We're checking weekly or biweekly to make sure the uterus is responding the way we want it to. Once it gets thick and we like the way it looks, now we need progesterone. The progesterone's for implantation. Okay. Again, there are different ways to administer the progesterone, primarily either vaginal or once again intramuscular, which is the shot in the hip. Now, here, oral, I didn't mention oral as a choice. Oral progesterone is not well absorbed. Okay, so we don't use that in preparation for embryo transfers.
Why not?
It has to do with sort of just the makeup of the medication and the way it gets absorbed through the GI tract. The absorption is poor. So it's
So
right.
estrogen is fine,
Estrogen is fine orally.
but
Okay.
progesterone isn't.
Progesterone is not.
Interesting.
It has to do with the biochemical nature of the molecule. So it's either vaginal or intramuscular or some combination of the two, okay, in these program cycles. Now you were asking about sort of needle fear. The progesterone the vehicle for the progesterone is oil called progesterone and oil. So when we inject the progesterone as an intramuscular shot, it can be uncomfortable. and especially kind of night after night, it's uncomfortable. Their hips get sore, they form little nodules. So not to be afraid, people do it, they make it, but it is the one that people will talk about as being uncomfortable.
And how many shots of estrogen would you take, and how many shots of progesterone would you take?
If an individual is taking intramuscular estrogen, it's usually a shot every third night. Okay, that's the most common. Remind you, there's many different ways to do this. That would be the most common protocol. Now, the way to give progesterone after, many different ways to do it. All vaginal regimens, all intramuscular regimens, a combination. And so how frequently you take that shot depends on the recipe your doctor has come up for you. Some people take it every night. Some people take it every other night. That would be probably the most common ways to deliver the progesterone and oil. Some regimens have just vaginal. Okay. The vaginal has, its downsides too. It's messy. There's a lot of discharge with the vaginal progesterone. So I have patients that prefer all intramuscular. And then I have, patients who prefer vaginal too.
And for how many days?
Lots of days.
Oh.
So we start the progesterone most commonly about 6 days ahead of the embryo transfer. But then hopefully you're pregnant. And if you're pregnant, which you find out about 10 days later, you'll be on those supplemental estrogen and progesterone until you're at least 10 weeks pregnant, sometimes longer. So you're on them for
3
a
months.
while. Yeah.
Wow.
Long time.
Okay.
Yeah. So it's a while. You are 2 weeks and 5 days pregnant at the time of the transfer. So you get a little bit of a head start. But then, typically on some kind of regimen until you're 10 weeks.
Back up a second.
Okay.
You're 2 weeks and 5 days pregnant at the day of transfer.
Day of transfer.
Why isn't
Assuming we've done a day 5
why isn't that
transfer?
day 0?
Good question. So by convention, we date pregnancies by the last menstrual period, in the world. Okay. In a cycle where an individual ovulates, and that's how they conceive with timed intercourse at ovulation, the day of conception, the day of ovulation, they are 2 weeks pregnant because we date by the last period. And most commonly you get a period. 2 weeks later, you ovulate. 2 weeks later is a missed period. And so if you got pregnant the old fashioned way, you would be 4 weeks pregnant the day of a missed period. Makes sense?
Yes. So
Yeah.
you're 4 weeks pregnant by the
So,
time you realize.
By the time you realize. And in IVF, right, our embryos have spent the first 5 days of their life, if you're doing a day 5 transfer, in the embryology lab, right? So instead of spending the first 5 days in the uterus. So this is now, we are mimicking the period of time of implantation, which is about 5 days after ovulation. Old fashioned way, you ovulate, that embryo hangs out in your fallopian tubes for about 5 days, boom, lands in the uterus. Okay. In IVF, first 5 days in the lab, okay, you don't ovulate in the cycle we've just described, but 5 days later, we put that embryo right into the uterus and it lands in the endometrium.
Wow.
Yeah.
I didn't know that.
Yeah.
Okay.
And then we typically do our pregnancy test about 10 days later, and that's when you're about 4 weeks pregnant. So realizing at the same time.
Realizing at the same time is just we've helped you along the way.
We've helped you along the way. Exactly.
Okay, perfect. So that's by taking medications.
That's what people will call a programmed or a medicated embryo transfer cycle.
Okay. What other options are there?
The other major way to do this is what we would call an ovulatory or a natural cycle. Okay. Concepts are the same. We still need estrogen, but now instead of giving the estrogen, the ovary makes its own estrogen. It's taking it. It's really only for a female who ovulates, who actually grows a follicle and an egg, makes estrogen and ovulates on their own every month. So in this type of cycle, you still have the estrogen around. You still check the lining to make sure the lining is thickening in response to that estrogen, but it's not what we call exogenous. It's endogenous. It's from the inside. So all that estrogen is actually coming from the ovary. So it's made.
So the body is creating its own instead of
estrogen.
Instead of injecting.
Exactly. But the purpose is the same. The goal is the same. It impacts the lining of the uterus in the same way. We're checking for the same things. Lining is getting thick. Does it have that beautiful trilaminar appearance?
So why would you do one versus the other?
Good question. People ask this all the time. There have been nice randomized control trials that compare the two, and the success rates have been found to be the same in most of those studies. Okay, so reasons to do one versus the other would be patient preference, okay, physician preference. Some physician may just feel like they looked at their data and they feel like their success rates are better with one versus the other, or they just have a sense that one is better than the other. Sometimes if you failed one, you might try the other, right? If you fail in a program, you try a natural cycle, or vice versa. There is some more recent data that suggests that things like preeclampsia and hypertensive disorders of pregnancy those risks are lower in a natural cycle. So you may have somebody who's already at high risk for those things, and you recommend more of a natural cycle. So those are reasons you might do one versus the other.
Okay. And is that...
Oh, let's continue. I'm not done with it.
Oh.
With that natural cycle, you have the body making estrogen,
yeah,
and then it ovulates on its own. Now the body's also making its own progesterone. Now I'll tell you, most doctors will still give some supplemental progesterone, okay? But the concept's the same. There's ovulation, that's the start of progesterone, and then the embryo goes in. The timing can't be programmed. The timing is just based on whenever that body has decided to ovulate.
So there will be an egg, but there will also be an embryo.
That's a good point. Yes, there will be an egg released, okay? And your doctor may tell you to not have intercourse.
I was about to say, could you end up with twins?
I have had a patient. Okay,
mind blown.
Okay, she was actually seen at this clinic. Because I'll tell you, so obviously there was a patient and she had failed many, many embryo transfers, many. And she was doing this natural cycle. She knew she was ovulating. She was actually a doctor. She was actually an OBGYN. She knew she was ovulating. Okay. And she had unprotected sex intentionally, thinking,
never going to happen.
It's never going to happen. Pregnant with twins. One from the embryo, one from the egg.
Oh my God, I love that.
Yeah.
We can make it happen.
Yeah, exactly. So yes, that's a really good point.
So she had a natural medicated IVF. She did it all and got twins. Good on her.
Yeah.
Okay, so you've got a medicated cycle, you have a natural cycle.
Yeah.
Are there any other types of cycles?
Those are the two main cycles.
Two. Okay. So we've done that.
Yeah.
Walk me through kind of what happens on the day
of the transfer.
Yeah.
The day of the transfer, you can eat and drink normally. So a little different than your retrieval day, right? Where you're getting anesthesia and they'll have you fast. You can eat and drink anything you want. Sometimes you'll be offered, some clinics will offer a Valium just to, people can be nervous, take the edge off. It's never been shown to improve success rates or hurt success rates. It's just, again, patient preference, physician preference. Some people will do acupuncture before if that's something they've been doing already. And then the day of, when at the time, sort of scheduled time, you get taken to this room, that'll be called the embryo transfer room. The room is itself connected to the embryology lab, right? Because that embryo, the embryologist will be bringing the embryo directly from the lab into the transfer room. Typically, they'll have you have a full bladder, right? Because having a full bladder makes the access to the uterus easier, right? So you'll get instructions about how full to try to make your bladder. They typically will check your bladder. Once you're in the room, we'll check your bladder to make sure it looks okay. Again, that full bladder improves our visualization at the time of transfer and makes the passage easier. So the day of the transfer, full bladder, right? The embryology team comes in to do an identity check. So it'll be important that the team comes in. Every clinic will have its own system. Here we use a digital tracking system. So you get scanned in with a barcode. That barcode needs to match the barcode that's on your dish, and it matches the barcode that was on the straw where your embryo is frozen. So that's an important part of the day.
Right.
Is sort of
make sure the right embryo is going into the
Correct.
right person.
To make sure the right embryo is going into the right person. So there's a lot of people asking your name and your birthday over and over again, asking you to confirm your name and birthday over and over again. And again, we use a digital tracking system for that as well. So that happens. The embryo's already been thawed, probably even before you arrive, because we like to thaw the embryos a couple hours before the transfer to allow them to re-expand. So when an embryo is frozen, it sort of collapses down, and they do best if they sort of re-expand. So it's frozen a couple hours warmed or thawed a couple hours ahead of the transfer.
Yeah.
So thawing happens before you get here. You arrive to the clinic, lots of identity checking, check on your bladder, make sure it's full. Once all those things are done, the doctor comes in and under ultrasound guidance, places the embryo at a very particular spot in the uterus. It's not painful. It doesn't require anesthesia.
With a needle or with
A catheter.
a
So
catheter?
a speculum needs to be placed to be able to identify the cervix, and this really soft, sort of noodly catheter is placed into the lining of the uterus. Again, you kind of want this sort of really the softest catheter possible because it's going into the uterus, right? To deposit the embryo in a particular spot. And so, it's a very delicate procedure, but it's kind of fun. Here we have this television in the room where you can see your embryo in real time. So the very last step is the embryologist making you once again look at your name on the dish, and then you see your embryo there in real time, and you see the embryologist draw the embryo up into the little catheter. And it's also really cool when you see the catheter, which is small, but it gives you perspective on how small the embryo is, because you can sort of see them together and you see them draw the embryo up. And then once the doctor has the catheter in the position, you'll hear them say, "I'm ready, we're ready for an embryo." And then that embryologist walks into the room with the little catheter, hands it to the doctor. The doctor, again, places the embryo right in the uterus. And then you can sort of see on ultrasound too, exactly where that embryo is being deposited in the uterus. That's pretty cool.
Can you video that?
Yeah, people do all the time. Yeah, take pictures, video. We give you guys, or we give anybody an actual picture of their embryo that day, but people will take their own as well.
Wow, that's amazing. And then what? They
just
get up and leave?
Yeah, then they get up and leave. There's a lot of debate. There has been a lot of debate over the course of time about how much time you should rest after a transfer. I mean, years ago, we made people stay in bed for weeks, and then we said, maybe only stay in bed for 3 days. Actually, maybe stay in bed for 2 days. Actually, you can actually just get up and walk away right after you're done. So the most recent data suggests that maybe pregnancy rates are even better if you just get up get up and go.
Do you have to kind of lie with your legs in the air? Just
this is sort of the analogy I use. The embryo is like a chia seed on peanut butter. It doesn't fall out.
Right.
It's getting
stuck in there.
It's stuck in there. Yeah. And so they don't fall out. We like people to get up we don't rush them out, but I think that resting for an hour afterwards doesn't improve outcomes, and data has shown that. Now again, we get people up, empty their bladders, go home.
But they're not going to pee it out.
They're not going to pee it out or poop it out.
Okay.
No, both are safe.
Both are safe.
Both are safe to do the day of your transfer.
Right.
But people worry about that. Now, what the activity afterwards, again, every doctor, every clinic will probably say something a little bit different. There's no real right or wrong answer here. I like to encourage people to take a couch potato day because they deserve it. I like to recommend comedies. One of my favorite one of my favorite patients told me, she was a midwife. She said, "I read a study. It was a pretty good study that showed laughing improves implantation." And who doesn't want to laugh anyway? But again, there's no right or wrong answer as to what you do from there. We go home and have a couch potato day or 2 couch potato days. Again, every doctor will probably, they'll sort of recommend something different. But the pregnancy test can be, 9 to 10 days later. At that point, you'd get a definitive answer from the blood work as to whether or not the embryo stuck.
That's amazing. Thank you very much.
Thank you.